Hey everybody, welcome to another episode of Mind Matters, Navigating Head Injuries and Concussions. My name is Kiley Como. I'm the legal nurse consultant here at Shane Smith Law, and today I'm joined by DrRuby with Family First Pediatrics. DrRuby, it's good to see you.
Good to see you too.
Of course, our focus here is to discuss, everything brain injury, everything related to topics around that. So today we're going to be diving into traumatic brain injuries in our pediatric patients and clients. But before we begin, DrRuby, I'd love for you to just kind of tell us a little bit about yourself, please.
Sure. So I'm a board certified pediatrician. I did my residency in Virginia and now reside in South Carolina, and I'm licensed in both North and South Carolina, seeing pediatric patients, and I'm certified in traumatic brain injury.
So let's just dive right in. I'm really curious to know, here at the firm, we see a lot of clients. We do see pediatric clients as well, minor clients, anywhere from ages 0 to 18. So we see the whole gambit, but they do bring with them a special set of circumstances oftentimes, especially when it comes to, traumatic brain injury. So that's kind of where I'd like to focus for our discussion today. So what differentiates, in your mind, pediatric, we'll stick with kind of mild TBI in terms of pediatrics versus adults in terms of their symptoms, treatments, recovery, just kind of give us an overall.
Sure. So just starting off baseline, children are very resilient and strong, but as far as getting into the depths of it, as far as their brains, they're still developing, correct? And so the size of their brain is at maybe 25% when they're born. And then by the time they're 3 years old, it can really grow to about 85% of an adult-sized brain. So that's just a lot of growth in that amount of time. And so there's a lot of space in their skull. So just giving that baseline perspective, that is wonderful because children are developing and so they're able to adapt to any injuries that occur. But that also makes them more vulnerable for certain types of injuries. It's so critical in the developmental stage, from 0 to 3 especially. And then even just at 3 to 18, they're still developing to that adult size, slower than the 0 to 3, but there's just a lot of space for injuries. Their skulls are much softer. They're still forming their fontanelles at, infancy until they get older. So they do have softer skulls than the adult skull. It's helpful because they initially can decrease the severity, but then they've got certain types of injuries where, shaken baby or diffuse axonal injury that can just cause a lot of long-term effects. The other thing is that, yes, cognitively and behaviorally, they're still trying to figure out how they're developing. And so that can really affect them long-term compared to an adult who really knows who they are. They kind of know their behaviors and mechanisms at that age.
That's a great breakdown. Most of my experiences in the world of adult brain injury, I come from a neurosurgical background in the ICU, and I hear what you're saying where the kids have the smaller brain, the larger area within their skull to kind of grow and flex. We have that as a disadvantage as adults, right? It's such a tight space up there that any injury or swelling, there's no room to move, so to speak. So I can see where you're saying how kids have that advantage, but then again, it can act against them as well. So that's fascinating. So we hear a lot about neuroplasticity. So how does that play in with, you kind of touched on a little bit of child's brain plasticity. How does that play into recovery, the recovery process after a TBI, and how might that differ from adults?
Right. So that's basically the fact that they can easily adapt to things, right? Because they're still developing, they can develop with an injury. That's the resilience of children. They're able to adapt to things. The issue with that is the vulnerability of those injuries, right? So as soon as they have an impact or an injury in a critical developmental stage, that can affect them long term.
When I think about children, and if I'm putting myself in your position, assessment is key. And so when a parent or a guardian brings in their child who they think may have suffered a brain injury, somehow they fell, hit their head, maybe they were in a car accident, as we're talking about here, I can see there being some challenges in diagnosing that. I know when you assess an adult, you can ask them direct questions. You can cue off some of their behaviors, as you mentioned earlier. How do you do that with a child, say that maybe not necessarily, maybe nonverbal because they're too young to speak, or maybe just don't have that complexity of speech yet to be able to describe complex feelings and emotions? How do you do that?
Right. So For infants and younger children, especially that are nonverbal, we really have to go off of their signs and symptoms and go off of what the parent awareness is. And so for us, it's, how are they eating? How are they drinking if they're just on bottles or feeds? And then how are their bowel movements and urinary movements? How are they using the restroom? Sometimes kids can be constipated, or because of their appetite decreasing and things like that, that can really affect them. The other thing is, besides their feeding habits, is how are they sleeping, right? So are they waking up multiple times in the night, having nightmares about the incident? Are they waking up early because they're not able to, go back to sleep or soothe themselves to go back to sleep? Are they just having difficulty going to sleep because when they close their eyes, they're reminded of the event? There's multiple different ways and things that can happen. And that's really important to educate the parents about this. Sometimes the younger kids, they're just inconsolable. You can't really get them to calm down. And that might be them having a mild traumatic brain injury. They're much more fussy. And sometimes, people can argue that it's part of their normal development. They're going to be fussy. They're going to have ups and downs. But sometimes mothers can really tell that, hey, my child did not have these inconsolable cries in the middle of the night. They were able to self-soothe, and now they just have an increased startle reflex, and it's just really hard to get them to go to bed. So there's different things that are happening, and the earlier that they're able to be seen, the earlier that they can have, treatment, then the better, effects they can have, and they won't have long-term effects.
Early diagnosis, early treatment, definitely key. Do you ever see those things coming on later though? So, the child was injured today or earlier today, I bring them in, you assess, you see what you see, but, I take my child home. Do I need to be watchful over the next days, weeks even?
Absolutely. So there also are symptoms of delayed TBIs. So for example, their changes in behavior can change. They were completely normal after the accident, and then all of a sudden now they're just showing aggression towards siblings. They're easily agitated. A lot of times kids can't say, hey, mom, I have a headache. I'm really bothered by it. They'll just act out, they'll show some sort of defiant behavior. Their sleep can also be affected, or they'll have physical symptoms. A lot of times kids will just start displaying twitching or seizures. That unexplained irritability and crying can also happen too. And those are some delayed symptoms. Or, sometimes the headache is happening, the TBI has happened and occurred, and then they've got worsening symptoms where it's a worsening headache, vomiting, they're just not able to wake up as often. They're sleeping a lot, so those are worsening symptoms that can happen later on, as well as delayed symptoms.
Bears watching for quite a long time. You must be you'd have to be acutely aware of your child's quirks. I like how you mentioned mothers. Mothers seem to have that, obviously that special bond and really pick up on cues quickly. So recruiting mom and family into the,
Right.
Management and monitoring of that is key, I'm sure. Kind of scary though, I imagine when you're talking to some of your clients or your patients, parents though, but I'm sure you've got ways of keeping them calm and focused. How do you then, so you do assessments, you've got, objective, observable signs. What about imaging? Do you ever use any imaging, say CAT scans, MRIs, other technologies to diagnose brain injury in children?
That is a great question. So the number one thing in the pediatric world is less radiation is the best radiation. So we do not want to expose any children to greater risk of radiation just because they're so young and they're still developing. And so that's baseline for any pediatric patient in the pediatric world. So we do prefer MRI, and MRI is the preferred choice for non-emergent situations such as a traumatic brain injury. And so for children, we are able to get fast scans completed in certain facilities if we're able to accommodate with certain technicians. And that's what really my role is. I'll call in to the offices or, say, hey, I've got a child. I think, they can sit still for about 15 minutes straight. And I've witnessed them, I examined them, and this is what I think. Sometimes I'm saying, what, this child's not going to be able to sit still and I can't complete this imaging. And that's, just a two-way communication that we need to have with the parent. I don't think they're going to be able to sit still. We're just going to continue to monitor them for now and, continue with these treatments. Other thing about DTIs is a common factor for checking for traumatic brain injury. And usually in younger children, you're not able to complete that. But at the age of 14 is when you're really able to go ahead and do that. So even though they're going through, pubertal changes at that time, that is most likely the time to do an MRI or a DTI, sorry.
No, that's excellent. I'm glad you brought up the DTI, diffuse tensor imaging. Not a brand new technology, but it's newish in its use in diagnosing TBIs. At least what we're seeing anyway. I wouldn't say there's just not a lot of availability. We'll say for big machines like that. So, but as we often see with MRIs, a lot of times they're unremarkable, clean, clear, whatever you want to call them on a mild traumatic brain injury. And so you're kind of left saying, well, I don't see anything. That must mean they're okay. But obviously, with the other signs and symptoms you're seeing objectively, that's not the case. So that's where that DTI really comes into play. I'd love for you to talk about the difference between the MRI and the DTI for our audience, because I don't think most people know what a DTI is.
Yeah. So as you mentioned, the diffusion tensor imaging, that's really the MRI, but it produces much more detailed imaging. And it's more specialized because it's looking at all the network and anatomy of all those nerve cells too. It analyzes all of that. And it provides, analysis on it for the special radiologist to read. And so for me, it's just the details of all of that are really helpful.
Yeah, I do love those. I've read a few reports from radiology after we've had clients that have gone to get those. They're fascinating, and they definitely shed light on those injuries like nothing else. So they've become a really valuable tool, I know, to us and our clients here at the firm. So I'm really glad you brought that up.
They can also just detect the smallest tissues and the blood flow. It's really amazing. Yes.
It really is, and I'm glad it's becoming more and more. I don't say mainstream yet, but I'm hoping that it does, and other technologies like that to help us diagnose such a mysterious injury yet as TBI. So let's move on from diagnostics into kind of the treatment realm. So once you've diagnosed a traumatic brain injury, what then? What are we going to do for this child?
So depending on the child, most often it's, mild TBIs that they're suffering from. And in that case, we have concussion protocols. Just like anything else in the pediatric world, there's return to work for adults. For children, it's return to play. And so what that happens is we go through a protocol where we just slowly reintroduce them to things. So for example, no screen time, if they need to rest, then they go ahead and rest for that time. As far as school, if, the whole day they're going through school and they're not able to have a headache, then they can go ahead and continue school the next day. But we do recommend that at least 1 to 2 days after suffering a mild TBI, they need to stay out of school, because that rest and, just to reset their brain is really important for them. As far as older children, athletes especially, we're so worried, even when they suffer from a mild traumatic brain injury, we're really worried about second impact syndrome. So that's where the return to play is, where, they're going to probably have to sit out of, activities for that week. We don't want them to have another risk of concussion and second impact syndrome. And so we want them to sit out from practices, from any sports, from running, from really doing any activities to exert themselves. And then from there, we go into, okay, now they can go to practice, once a week, twice a week, just slowly reintroducing them to these activities so they don't have any of those post-traumatic headaches or any of the, secondary effects.
I love that you brought that up. That was where I was going to go with that. The kind of the older child, that teenager, adolescent. I'm sure you see quite a bit of sports-related concussions, that sort of thing where you are. And I know the old school way of thinking was rest is best, right? You get them in a dark room, put them in the bed, don't bother them. But that's no longer, you kind of touched on, that's really no longer the protocol. You've got things like the Buffalo treadmill concussion protocols, all that sort of thing. The verbiage may be a little twisted around there, but really tapping into getting them back to activity as soon as possible. Is it? Yes. Do you work? Do you see a lot of that kind of treatment?
So we, as you mentioned, those, touching on that is basically we work with the school. So we have the parents talk with the school, the teachers, the coaches, if they need to, let them know that they suffered a traumatic brain injury. And then going from there and just basically saying we're slowly reintroducing them back to their normal way of life. But we also want to make sure that if they have these post-traumatic headaches or the nausea or whatever symptoms they're having, that they are decreased. So then we can reintroduce them to the next steps and just slowly, gradually. And honestly, teachers and coaches, they're all willing to work with the family because they just want the best for the child.
Yeah, that's true. My wife and I experienced that firsthand with our youngest son played football and got a concussion. And our doctor worked with their trainer, and it was really an amazing collaboration. I didn't realize that there was that much communication, to be honest. So that's I'm really happy to hear you say that. That's a big step forward from where we used to be back in the day. So
yes, and I think they're educating, providers and coaches and teachers about concussions and TBIs and symptoms to look for. So everybody's just really able to collaborate in that sense.
Yeah, education is definitely crucial. So kudos to you on that front as well. Okay, everybody, that's going to do it for another episode of Mind Matters, Navigating Head Injuries and Concussions. I really want to extend my appreciation to Dr. Ruby for joining us today and sharing her wonderful knowledge and expertise with us. I'd like to have you all just please hit that like button and subscribe to our channel for all the latest and greatest content. And as always, remember, if you're in pain, call Shane at 980-999-9999.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.